Welcome to the CodeCast podcast. Real-world insights for your daily medical coding and billing processes. And now, here's your host, Terry Fletcher.
Hello, everyone, and welcome to the 147th episode of the CodeCast podcast. My name is Terry Fletcher. Today, I wanted to talk to you about the proposed 2021 physician fee schedule for Medicare. There are a lot of surprises in there that I wanted to make sure you were aware of instead of going through the whole 1,300 pages and then some for that proposal. Now, this is a proposal, yes, but a lot of things have been signed with not only executive order, but they're expected to pass, but there is a comment period that you have until October 5th. So as a stakeholder, and we are all stakeholders. I am, you are, your patients are, your physicians are, as a coder and biller you are, because you have a stake in what the reimbursement will be because it relies on your paycheck. So everybody's a stakeholder. But in an election year, anything can happen. So this is the likely plan for 2021, and you need to be ready for it. It is going to have a huge impact for your practice and your physician. So we want to just make sure we're on top of it. The CodeCast podcast is also brought to you today by Charles Schwab. Be a more informed investor. Follow us for news and insights to help you own your tomorrow. AboutSchwab.com. Okay, so let's get started. And I also did something similar on Monitor Mondays, which is a podcast offshoot for RackMonitor.com. So if you're interested in seeing that, feel free to take a look. I have an article coming out that will have all of the proposed Medicare policy changes and everything, and that'll be on my website as well at terryfletcher.net. So we just have to really, take a look at what's going on. It is crazy because everybody's so focused on, are they extending telehealth and what's happening with that? And it's funny to me because there is more to life than telehealth, but we do have to talk about that as well because you never know what is going to happen when it comes to the extension and if they're going to relax some of the flexibilities even more or if they're going to roll back some of them, how it's going to affect you when it comes to payment parity and making sure that you know where your money's going to come from. But let's just face it, we have a lot to cover. There's a lot to go over. There was a newsroom fact sheet that Medicare put out on August 3rd. And so I'm going to be kind of summarizing some of that. And then also letting you know why certain things happened and explaining a little bit on where we're going with some other things. So what this is the 2021 final payment rules. And so everybody's like, oh, it's done. No, this is a proposal. And again, you have until October 5th to comment on it as a stakeholder. But looking specifically, and there's other things, there's the OPPS, which is outpatient hospitals. There's also inpatient hospital information. There's all kinds of things. But I want to look at what's going to happen to physicians specifically, because, I'm a pro-fee coder. And also some of the surprises were mainly because the Budget Neutrality Act was ignored in the public health emergency. And with all of the flexibilities and monies that were pushed out for telehealth, makeshift hospitals without walls, all of that, and then added providers even under the telehealth, they kind of ignored that Neutrality Act. And now the real rules and laws must be held up or the Medicare fund could find its way into running out of money by 2026, according to the Medicare trustees report. And that would be bad. So what a lot of providers tend to look at, including hospitals, hospital CEOs, even some of the telehealth vendors out there, which I'm ready to shake them a little bit, because it's just like, can you take a breath for a second? Let's just see how well this is working. Let's just make sure we know that it's effective care and not just convenient care. We shouldn't sacrifice access to care for standard of care. And that's what's been happening in a good percentage of telehealth. And so it concerns me that no one's taking a look until now. Actually, this past week is when the audit started back up on August 3rd, as I mentioned in our last podcast. So oversight is finally being looked at, but oversight means that you're kind of looking over somebody's shoulder while they're doing it. Now, this is kind of a retro oversight, which is just going to be a nightmare. I just know what they're going to find, and it's not going to be pretty. But we first want to, and I want to just put it out there, I really appreciate CMS, just trying to make things right. They're kind of rewriting the reimbursement playbook. And they're doing it during a pandemic. They're doing it during an election year where there's so much anger and hostility on both sides of the aisle. I just appreciate their efforts just so much, because otherwise nothing would get done. Let's face it. We know what's going on out there. But here are some of the facts that came off the newsroom fact sheet. And I just want to make sure that you are aware of it, because this is pretty big. So a lot of times we will see in the news that we're getting a raise in our fee schedule, when actually we may get a raise in the value of the code, but not necessarily in the fee schedule or the conversion factor. And that's the multiplier that's used against the RVU, or the relative value unit, to determine the price or allowable for a medical service. And so we want to know exactly what we're getting before we kind of jump into something and say, oh, well, this is what we deserve. But keep in mind something else too. When I talk about RVUs, and again, that is the relative value units, and that is what is used to break down a service into three components to assign a price to them. The RUC committee, which is the Resource Use Committee for Medicare, they rely on data collection and expertise of this committee, and it's also run by the American Medical Association, to do surveys and comprehensive work to figure out the valuation of certain services, and then come up with a price for it, or basically a RVU for it that's used against a conversion factor. So the work value, for example, time and level of difficulty required of the healthcare professional. And then you have practice expense, which is support staff, infrastructure, building, utilities, EHR, the supplies required for the service. And think about that when we talk about telehealth, because a lot of that doesn't exist anymore, especially if the physician's at home and the patient's at home, and you don't have to have a waiting room or an office for the patient, an exam room. Then you have malpractice expense, and so that's the estimated cost of insuring the service against the malpractice claims. And so this is a formula that the RUC committee concluded that has to be adequately looked at, and significant services and increases and decreases in some areas to be able to get a more appropriate cost or price for these services. And so that's what is really being monitored right now. Well, in saying that, the proposed physician fee schedule conversion factor, again, the multiplier, is proposed to go down almost 11%, 10.6% to be exact, from $36.09, that's what we have now, to $32.26. And that is huge. And remember, this is based on the budget neutrality. If you push out money, and if the CMS is paying for things, they got to find a way to pay for it. Well, that means they take it from other places. This is a law, and they didn't think about that during the public health emergency, or at least it didn't factor into decisions about what they were pushing out. And now that we're getting ready for a new year, they have to. And so even though, again, the RVU may increase, as we've been told it will, the conversion factor is supposed to decrease significantly. Where you'll see those decreases mostly will be in surgery services. So orthopedic surgeons are going to get killed about 5% when it comes to some of their surgeries. You're going to see it only in the E&M new patient level 4 and 5 visit. So you'll see it at about 11% decrease in the level 4 and about a 2% level 5. And then in the established patient visits, you're actually going to see an increase of an average of about 12%. They range from about 11 to 17, depending on what you're using. And so that will definitely make an impact there, but we have to be very careful with that as well. Now, CMS proposed adding several services to the Medicare telehealth list, and they already did during the public health emergency, which we have been extended, as you know, through October 26th. And they've also included now what they call home visits for established patient visits. Now, that seems silly sometimes, because I want to clarify in the home visits. Since the patient's already at home, what's the difference between a physician seeing them via telehealth at home versus a home visit? A home visit is for providers who work for a home health agency, and they see patients at home, versus a telehealth visit versus a patient who regularly sees their physician in person. But today the encounter is delivered via telehealth. So if you're seeing your physician in person, or if your patient is, and now they're being seen under a telehealth visit, then that's still an office visit if it's audio and visual. But if it's a telehealth agency, then that would be considered a home visit. And right now those weren't added or included in the telehealth, but they are going to be now. And it's going to be considered possibly a higher value there. Now, I do anticipate parity rules being rolled back. So right now they're paying exactly the same, but when you look at the value of the code, that doesn't make sense when it talks about work value or overhead. And then also, one of the things that CMS Administrator Seema Verna tweeted out last Tuesday actually, is this is what she said. She says, we are seeking public input on telehealth and other services to permanently add to the telehealth list beyond the pandemic, beyond the public health emergency, in order to give clinicians and patients time as they get ready to provide in-person care again. So they said, telemedicine can never fully replace in-person care, but it can enhance increasing care by, helping with access and making sure that patients can be seen. And it can give also some better choices or some different choices for American seniors. But what needs to be taken seriously is that telehealth is not the same as in-person. I can't tell you how much it drives me crazy when I argue with somebody, mostly a telehealth vendor, who says, oh no, it's the same thing. I'm like, okay, let me give you an example. And actually, if you listen to me on that rack monitor, you would have heard this as well. My father-in-law, who was just diagnosed with Hodgkin's lymphoma, started with a rash on his inner thigh about 4 months ago now. And basically, he didn't know what it was. He's 92 years old. And he basically called his doctor and has told his doctor over the phone, because we were in a lockdown at that point. That's when we were all quarantined, told to stay home. And he said, what do I do? Well, just from over the phone conversation, he gave him a topical ointment. Okay. Well, that didn't work after about a month, and it was starting to get worse. And around late April, he started experiencing oozing as in a form of a cut right at his inner thigh as well. And he said it just looked like an open sore because maybe he was scratching the area from the rash he was getting, which was starting to spread on his legs. He went on for another month. And I said, Dad, what are you doing here? Again, my father-in-law. And he says, can you come look? I know that you have a nursing background. Can you come look? And I said, yes. So I went out. He's about an hour from where we live. And I'm like, no, you need to be seen. And he goes, they won't let us come in, and they want me to do this telemedicine thing. And I said, okay, what have you done so far? He says, I called, they gave me an ointment. So then the doctor hooked him up for a telehealth visit. I wasn't there for that. And they did it off his phone, which I showed him how to work his FaceTime because he has an iPhone. And he said, he just told me to not worry about it, to put a Band-Aid on it, and it should be fine. I'm like, you're kidding me. So then another couple weeks, now it's starting to get painful, and he's having a hard time walking, even with his walker. And so I said, you know what, we're going to take you to a different physician. Let's get you into a specialist. So I took him to a general surgeon, bypassed his primary care doctor, said, we'll just pay for the visit if we have to. Turns out he had a tumor the size of a golf ball in his inner thigh that was rising up to the skin, and that's what was oozing. And he was diagnosed with Hodgkin's lymphoma and had to have life-saving surgery. How many times is this happening to patients where they are giving their, non-clinical assessment to a physician because they're a patient? They don't have any kind of education. They're giving uneducated assessments. I had another friend who finally got to get into her dentist. She thought she had a really bad toothache that was pushing on her inner ear. Turns out she had a thyroid nodule that turned out to be cancerous and had to go through chemo for 6 months, but could not get in. And they wanted to just look telehealth. Telehealth is a good stopgap, but it's not the end all for everything. And you have to be mindful of that. It will cause not only some malpractice issues, but it'll really hurt patients in the long term if we think it replaces in-person care. And I cannot be strong enough about that. It never fully replaces in-person care. It can be a good stopgap. It can be a good in-between. But let's get serious about this. This is becoming such an issue. It's actually, I'm on a soapbox. I know that, but it's just bugging me because I just can't get some vendors to realize, and some providers to realize that, yes, it might be convenient and it might be great access, but the standard of care is tremendously lowered when we just think that's all the patient needs. The department also proposed adding the following list of services to the Medicare telehealth, and they called it Category 1, basically meaning that audiovisual, but they want to add the complexity code. So I'm sure you've heard in the E&M 2021, I just taught a webinar on that. I have a webinar series, don't forget, and it'll be part of the second session. But there's a code out there, HCPCS code, GPC1X, that is considered a visit complexity associated with certain office and outpatient management. So it means the patient is more complex, that you're actually dealing with some things on an ongoing basis. It's worth about $15 extra in addition to the E&M, and they're thinking about adding that. Prolonged services based on time for audio and visual, some group psychotherapy, neurobehavioral status exams, some other care planning services, and then again, some home visit with agency providers. But they're trying to figure out how to align these services to make sure that it's reasonable, and that if they're going to go forward with it, that there is something that reflects that the quality of care is still there. Now, I was in a webinar recently, and I actually disagreed with the person that was presenting it because that's not how I read the proposed change. So this is an important notation, and I know that they're going to get their, meaning Medicare. There's a lot of lobbying power out there for them to do what they want to do. And I wish it wasn't an election year, because I think a lot of changes, even in telehealth and a lot of things that are happening, have been done, yes, for access for patients and because we're in a pandemic, but they've been done to say, look what I did, and, look what I pushed for and got. And that's not the reason to push something out. That's the reason to do it is because you've got some proven information that can reflect clinical outcomes based on evidence-based medicine. Show me how this works based on this other service that we're providing. So this is an important note. CMS singled out one specific service in their proposal that it does not plan to continue, but it is soliciting input, which I wish they said they wouldn't, because the fact that they are, I just have a feeling they're going to extend it to some point. And that's audio-only visits, so phone calls. CMS has allowed these visits during the public health emergency, as you know, and they've allowed it with phone call codes 99441 to 99443 or virtual check-ins, G2012. But these are when there's no video available, and they're limited because they're all based on time. And the phone call codes, you can only bill once every 7 days, and the virtual check-ins only worth about $12. Discontinuing coverage would run against some trends in the state level. I know in New York, they added it and approved it for participants in state-administered Medicaid and the CHIPS program for kids insurance. Also, New Hampshire in July added it as a permanent extension just of the emergency telehealth measure. But the one thing that the states and the other providers that are really pushing for audio-only access to video is that the lack of, well, let me rephrase. We understand that patients have a lack of access to video technology, and some patients have not caught up to that, or they don't have good internet connection, and it's usually among the underserved populations. Okay, and that's who's pushing really to keep the audio-only telehealth. But the CMS discussion, and I was listening on the listening call for them, they've said that these providers have not, and these states have not provided evidence-based medicine and clinical outcomes to address the clinical value of phone calls only, the quality of care, and how frequently these visits should be allowed. And so CMS has acknowledged that audio-only visits do have certain value for patients, especially during the COVID-19 setting, because they want to avoid potential exposure. But we're on the downswing now. And many clinicians, many advisory board researchers that not only has CMS talked to, but they're advised from, I've talked to certain advisory boards, they seem to be really uncertain of the clinical value of an audio-only visit. And I gave you a perfect example before. There are obvious limitations to the kind of examination that's possible with audio-only interaction. And it's more information just being related by an uneducated, and I mean medically educated, patient. And so there needs to be more information before they put this into a permanent basis. And again, CMS does not want to see this as a replacement for in-person care. Or what I could see is not only overutilization based on convenience, but also a huge fraud scam. So we have to be very careful with that. And that's going to be a problem. Also, remember, with anything on the phone, you can't use it for your HCC model. So that's definitely a problem. Under the proposal, the implementation of your MIP, so your merit-based incentive payment program, that has been delayed to 2022. So that's actually good. And then some of the other things that are out, I mentioned the 5.4% decrease for orthopedic physicians, mostly on the hip and knee replacements. But also, I noticed that the American College of Surgeons have similar concerns, saying that we're seeing at least a 2 to 3% cut on a lot of general surgery services. But the reason that is happening is, again, because of the budget neutrality. And one of the biggest impacts from the announcements that have been made in the last few days is the fact that they're trying to get rid of, CMS is trying to eliminate that inpatient list only. So, for example, if you need a knee replacement or if you need a colon resection, there's a list out there saying that it can only be approved if it is performed in an inpatient setting. Well, they want to do away with that list so that now it's based on the risk of the patient. But to me, that's going to really, I think the list needs to just be pared down, because if you get rid of that list completely and you have a payer that also gets to decide where the patient's going to have it, not just the physician making the decision based on the overall risk on the patient. The hospital, let's just say for gallbladder surgery, they charge like $40,000. But if you can have a laparoscopic chole, let's say at an ASC, you're looking at more like maybe $15,000. Well, pick one. But what if the patient's diabetic, also has a heart condition, and that patient also is uncommitted and needs to maybe have hospital team there, something to that effect, because of their comorbidities? I would want that in the hospital, even as an outpatient. Well, it's going to get expensive. And so there's a possibility that the payer could disagree. So I think sometimes they're not thinking through these things. And one of the things that I'm having a really hard time with is whenever there's new things that come up, and Medicare takes forever. They basically say, oh, great, let's get a thought group together and let's decide if we're going to do this in 3 years. And in the last 4 months, they have pushed out so many new things. And again, I realize we're in a pandemic, and but telehealth, 144,000 visits were basically done in, let's say, in a week's time before February. 10 million visits have been sent in between March and July. I mean, do the math. They've got to be thinking, whoa, everybody just, pull back the reins here. So it's definitely going to be interesting to see how that all pans out after the comment period. Then the other thing under the proposal is about supervision. And this is kind of interesting on clinical supervision. Right now, one of the definitions under the flexibilities, there is a temporary revised regulatory definition of direct supervision when it comes to via audio, video, real time, when it comes to certain diagnostic tests. And so they want to extend that, where basically the nurse practitioner, PA, clinical nurse specialist, clinical nurse midwife is similar to the physician, or I should say same. And then they're going to be able to be the supervising provider for those tests, and the allowables will be at 100%. Now, they did say we're not only seeking public comment, but we need to know whether it should impose any guardrails on that policy or consider extending it further from a temporary position to maybe looking at it a little bit longer before they actually implement it as a final position. And yes, not only guardrails, but handcuffs, whatever it takes to realize that even though we love our mid-level providers, they are extenders of the physician. They are not physicians. And so things could be missed, and I think that could be problematic in the future. So just remember, with all this and everything I'm talking about with this, that you are a stakeholder. Make sure that you instruct your physician or really push them to go to regulations.gov and follow the submit a comment instructions, and it'll be right there for the Physician Fee Schedule 2021. So just have them look for that and research it out, and they will find it. But yeah, it's really going to be interesting to see on that submit a comment section and what everybody does before October 5th, to see if it's actually going to be finalized or what's going to happen, and then also obviously before November. Also, if you want to read the 1,353-page proposed rule, you'll be able to find it under Federal Register. Actually, you can Google search the proposed rule. Just put proposed rule, public inspection, the physician fee schedule, and then just put 2021, and it comes right up. I'm probably going to add it to my website as well. And so if you need to find it, you can find it there as well. Okay, let's take a look at my coding question today. And the coding question is actually a compliance question. I thought this was a good question. So it says, Terry, I have a question on provider signatures because we recently had an ambulance come in and tell us that they didn't have to have it anymore. So does that mean that we do? It says, like many practices, we're doing a lot of telehealth during the public health emergency. Does this relieve or reduce our provider signature requirements for our Medicare claims like it has done for ambulance? I'm like, okay, so CMS has been very clear that providers in general are expected to sign their work as before or authenticate their work. In an FAQ on COVID flexibilities updated July 24th, CMS said that it waived patient signatures in some cases, for example, for proof of delivery of durable medical equipment, prosthetics, or other orthotics and supplies, or delivery of Part B drugs, as long as the person delivering it or the delivery company took a photo that it was delivered with the address. They also said, but in the same FAQ, the agency reminds providers that services and equipment furnished to the patients must be reasonable and necessary, and accordingly, the medical record should be sufficient to demonstrate that the payment for the services is warranted. And they said, which requires the signature of an enrolled provider or supplier. So they still want you to at least prove that it's necessary. The one place where providers see signature flexibility is in the ambulance. Because of limitations caused by COVID, CMS just said they're not reviewing to make sure that's compliant. It doesn't mean that you shouldn't do it. I would still do it. And then basically put in the medical record, you couldn't provide a signature for transport orders because of COVID. But other than that, no, you have to sign. So there's a lot of different things on patient portals, emails, DocuSign. All those have a compliance package there to where you can comply with Medicare with their signature requirements. Also, make sure you look up the MedLearn Matters booklet revised in May 2018 on signatures. And Medicare was pretty clear on that, and they have not scaled that back at all. So make sure that you are looking at that because of your malpractice as well. We don't want you to get in trouble. Our coding question today was brought to you by Ozark Medical Coding. Join us for the Advanced Cardiology Virtual Summit, September 11th and 12th, all on demand with question and answer opportunities both days with me and 3 other speakers. Go to cardiologysummit2020.com/register. I hope to see many of you there. Some of you have asked, when is the next, big cardiology summit? And this is over 2 days. We're doing them all on demand. It's me, Stacy Buck, Jennifer McNamara, and one other speaker that I am losing it right now. I can't think of his name, but very nice. And so it'll be cardiology, it'll be ICD-10, it'll be peripheral vascular, and I think there's also ICD-10 PCS. So if you're interested in that, make sure you again go to cardiologysummit2020.com/register. So I'm going to end with my personal tidbit this week, and some of you know me, or at least have heard me talk about my daughter all the time. She's an adult daughter, but we're very close, and it looks like she's an English teacher and having a tough time finding a permanent position. As now with the pandemic, she's like, you've got to be kidding me. But it looks like she could be moving to Arizona, and I'm in California. And so she's just about done with her master's program, but she's been a sub for 2 years, was a long-term sub prior to the COVID shutdown. And she just wants her own classroom. And it looks like she was offered a private school, middle school position as a English teacher. And so we're going to find out for sure in the next day or so. She had her 3rd interview today. And I'm sad. I'm proud of her, but I'm sad. But at 25 years old, she's so ready to get things started. So hopefully she will get the job. I say that with a little bit of hesitation, but at some point we just got to let them go. So for those of you that have your teenage kids still, be thankful, because I'm definitely going to have a period of mourning. I just want to let you know. But I am really happy. So everyone, make it a great day. Thank you for spending some time with me today on this Terry Tuesday, and have a great week as well. Talk to you next week on the CodeCast podcast.
For more information on medical coding, billing, auditing, and compliance, including how to hire Terry, follow Terry on Twitter @TerryCoder1 or visit her website at www.terryfletcher.net. Podcast producer Joe Kuzma. Music producer Dassassin Music.